रविंदर,
या
पिछले प्रोग्राम्स की रिकॉर्डिंग मेरे पास अभी तक नहीं आई।
सर मैं शेयर करवा देता हूँ।
हाँ बस
हैविंग दैट, और ये भी आपको शेयर कर देंगे।
हमने तो एक एक्सरे का मॉड्यूल 4 किया था फैजल के संग, उसकी भी रिकॉर्डिंग नहीं आई हमारे पास।
सर वो वाला तो मुझे आइडिया नहीं है, बट जो आपने टीबी डे में मेरे साथ किया था,
आपके साथ किया, जरा वहां बात करिएगा जो आप लोग करते हैं, और 1.5 साल 2 साल पहले बीच में हुआ था, 1 साल पहले। ओके, गो।
So it's 3, 2, 1. We are live to the audience. Over to you.
Yeah. So good afternoon, all the delegates. First of all, I welcome all of you for joining this webinar. Today we have the renowned chest physician and pulmonologist, Dr. Rajendra Prasad from the Lucknow. And before getting into the webinar, let me give the brief introduction about the sir. So sir is the Professor Dr. Rajendra Prasad, MD, DTCT, FAMS, and FSCCP, USA, FRCP, Glasgow, WHO Fellow, Japan, and Director Medical Education, and the Professor, HOD of the Pulmonary Medicine, ERA, Lucknow, and also former Director of the VALLABH PATEL Chess Institute, Delhi. He is also awarded with the BC Roy National Award, Vice Chairman and the National Task Force of the RNTCP India, Senior Vice Chairman, UP Tuberculosis Association, and also the former Director of the UP Rural Institute of Medical Science and Research, SAIFAI, and former Professor and the Head of Department of the Pulmonary Medicine, KG Medical College, Lucknow, and also Vice President of the South Asia Association of Allergy, Asthma, and the Clinical Immunology. So the list goes and on and on. So now getting ahead, I hand over the session to Sir to take it forward. Sir, it is up to you.
Thank you, Ravinder, for a nice introduction. And my job today is to talk to you all about the diagnosis and treatment of drug-sensitive tuberculosis. Today, I'll just deal with drug-sensitive tuberculosis, literally all the aspects of drug-sensitive tuberculosis. Let me share my slides. So, sorry.
May I help you, sir?
No, I can. I think my slides are visible.
Yes, sir.
So, as I just said that today I will be focusing for next 40 minutes, 42, about the diagnosis and treatment of drug-susceptible tuberculosis, what you call is drug-sensitive TB. And these are my institute where I have worked. This is my old KG Medical College. This is SAIFAI. This is Patel Chest. And currently I am working in ERA Medical College. My agenda today would be what are the updates in the diagnosis of DSTB, drug-susceptible TB, or drug-sensitive TB. What are the updates in treatment of drug-sensitive tuberculosis? And maybe last 3-4 minutes, what would be the future of tuberculosis treatment? Especially, I will focus on drug-sensitive tuberculosis. You know, when I talk about tuberculosis, some of you might have listened me previously. This case I treated in 2004. You see, there's a bilateral extensive disease, sputum for AFB at that time gene experts not available, so positive. And after 6 months of therapy, you know, his lesions are drastically reduced. His sputum become negative, and patient is still on my follow-up. He is still alive. In 2007, you know that most of the shadows which are left after 6 months of treatment were cleared without any treatment. So this happens in tuberculosis. So if you treat just radiology, you might over-treat the patient. So this is another case, there is a cavity in the left lung and which has under the chemotherapy has closed, and there is hardly any lesion after complete therapy, 6 months of therapy. What I'm going to say that to me, in last more than 4 decades of career, I must have treated lakhs and lakhs of patients of tuberculosis, and majority of them have been the drug-sensitive tuberculosis. And I say it's a 100% curable disease, provided adequate treatment is prescribed and it should be taken by the patient. Both the things are very important. Then it is curable. There will be hardly any relapse. There is hardly any drug resistance. So what I'm trying to say, if you treat all drug-sensitive tuberculosis, which is around 95%, more than 95% of the TB population, then it is 100% curable disease. But it is very unfortunate, you see, as per global TB report, about 1/4 of cases, we are the highest in TB cases, India. There are a large number of deaths, about 1.5 million deaths globally last year. In India, around 5 lakh deaths has happened. And the time I will spend with you, maybe 20-25 people would die of tuberculosis. Always, I said in my first slide, it is a curable disease, but so many deaths are happening, and only reason is, if you just examine very quickly, that when patient gets tuberculosis, he goes into private sector or government sector. Many times they cross sometimes from government to private and private to government. This is the story of most of the TB patients. And TB management in public sector, government has revised National TB Elimination Program, and large number of patients. Last year, if you see, about 20 lakh TB patients, out of 26 lakhs, 21 lakh TB patients, in spite of the COVID, were registered and were treated. So government is providing all the facilities, free of cost, diagnostic treatment. But unfortunately, not all the patients are going to the government. So many patients are going to the private sector. Let's examine how in the private sector TB is treated. I can talk for hours, but I'll not take that time. A lot of papers have been published. This Upelkar paper is very popular. He says in city of Mumbai, he says in 91, city of Mumbai, 100 doctors prescribed 80 regimen. We took similar study and published 2002, 33 different regimens. And most of you see the red lines, most of the doctors made prescription error. That is what is happening in the private sector. At that time, still it is true. Still we see a lot of bad prescriptions in tuberculosis. So somebody has done a meta-systemic review and said there is a suboptimal quality of TB care. Particularly, that is why you must have understood why people are dying because of suboptimal care of tuberculosis. Even drug quality is also important. We did a study way back in 2004-05, and we find about 15% of the drugs, we don't know what is the quality of those drugs. So you know that, so you must have understood it is the poor quality care, poor quality drugs sometimes, and poor management. If suppose you are suspecting resistance, although today my talk is not on drug resistance, but poor management of drug resistance. This is how people are dying. How today TB is diagnosed? I'll confine myself to the drug-sensitive tuberculosis. Now now there are only 2 types of diagnosis must be written on your prescription, whether it is microbiologically confirmed TB case or it is clinically diagnosed. When I say microbiologically confirmed, it means that Either it is confirmed by phenotypic, that is sputum for AFD, sputum culture for MTB, or genotypic by gene expert, LPA, anything. By anything is TB is proven, then it becomes microbiologically confirmed. Rest of the cases, they are clinically diagnosed. I usually narrate, suppose somebody had got lymph node, you did FNAC. If the diagnosis is by few cells, cytology, it becomes clinically diagnosed. But suppose in that smear, you demonstrate AFB, or you demonstrate gene expert, then it becomes a microbiologically diagnosed cases of tubercular lymphoid node. So now we should write in our prescription whether your patient is microbiologically confirmed or clinically diagnosed. Another change has happened. Here is a recurrent term, what we used to call it as relapse, that name has been changed to recurrent. And another thing has changed. We used to say TB suspect, now it is known as presumptive TB. So these are the changes. And you know, all you must be treating tuberculosis, presumptive pulmonary TB, cough, hemoptysis, fever, weight loss, any pulmonary abnormalities. These are known as, if they are there, you presume that yes, patient may be suffering for presumptive tuberculosis. And now, what are the various methods to diagnose sensitive TB? You have a smear microscopy, you have CB-NAT, means gene expert, you have a culture, you have a chest X-ray, you have tuberculin test or IGRA, you have cytology like FNAC, you have histology. So all these methods are there to diagnose tuberculosis. And then if you wanted to do a drug susceptibility test, here in drug sensitive also, you wanted to prove whether you are really seeing a drug sensitive. Now today we have universal DST, means every new patient must undergo CB-NAT. So on the day one, you should know that whether CB-NAT, LPA, whole genome sequencing, lot of things are, molecular tests are available today. And there you have to, you have to say that so diagnosis you have to prove, and then you have to say that yes, you are dealing with drug sensitive tuberculosis. Culture can also be done. So this is various methods are available. I'll skip some of the slides. You know, radiology is, although it is a very sensitive method, but not very specific. And old X-rays sometimes help you. And CT thorax sometimes may be required. Now, this is a typical X-ray picture, you know, where there is a cavity on one side and then infiltrates on the other side. And this is lymph node, hilar lymph node, proven to be tubercular. And this is a mediastinal lymph nodes, potato-like shadow. This is again proven to be tubercular. Pleural effusion. So this is a healed tuberculosis. We have seen many times, we've healed tuberculosis, they have hemoptysis, and sometimes they are being prescribed anti-TB drug. Another method of healing is cavity healing. You have seen the first case where cavity has closed. That is known as close healing. Here you find the cavity is thin wall cavity is persisting. It will persist throughout the life of the patient. And what we call is the open negative syndrome, means sputum is negative and cavity is persisting. It may have a lot of complications like hemoptysis, like aspergilloma. You have seen in your day-to-day clinical. So such type of patient, they are not. So what I'm trying to say, you have to prove, yes, you are seeing active case of TB, and secondly, you are seeing a drug-sensitive TB. Sputum bacteriology, no doubt, we have to do repeated sputum, even in program, there are 2 sputum, you can do more than 2 in a difficult scenario. Culture you can do in difficult scenario. X-ray based evaluation always caused overdiagnosis. You know, we did a study again, how TB is diagnosed. It's little older study, but it talks something. Only 99, most of the doctors use chest X-ray only for the diagnosis. Very few advise sputum. So, a non-utilization of the sputum microscopy was associated with higher probability of prescribing anti-TB drug in patients with non-tuber. We see day in, day out, and this we have proven. And what are the other diseases where they are misdiagnosed as tuberculosis in that particular paper, like cancer, COPD, healed tuberculosis, bronchiectasis, lung infection, asthma, all sorts of disease can be misdiagnosed, what I'm trying to. Then we have to diagnose CB-NAT. You know, advantage of CB-NAT is give sputum bacteria, presence of bacteria, and also it gives you the DST. So that is known as universal DST. Within 90 minutes, officially speaking, you can get this result. Gene expert ultra is little advantageous over the gene expert because you need a possibly sample, even this could be positive. Even in extrapulmonary tuberculosis, gene expert is very helpful. It is helpful in CSF, it is helpful in lymph node, it is helpful in gastric lavage, it is less helpful in pleural. That is how. So with these, you have LPA. LPA also detects MTB, and also it further detects, LPA1 detects INH resistance. It is low level of INH resistance or high level of. So with all these, with diagnostic algorithm, you know there is established diagnostic algorithm for drug-sensitive tuberculosis, in which, you know, smear examination, X-ray, CB-NAT, they have been amalgamated together to make the proper diagnosis. There are other ways to diagnose. Histopathology could be another way to diagnose. There's one more way to diagnose tuberculosis is treatment or clinical suspicion, empirical therapy. Still it exists. Many times we see cases when we suspect tuberculosis, our initial suspicion is very high and we are not able to prove it. And in this scenario, when other diagnosis is excluded, then we give anti-TB drugs. And if he responds to anti-TB drugs, then TB treatment should be completed. That is what is known as empirical therapy for tuberculosis. And gene sequencing is coming up new, and many new things are coming where you can find the drug sensitivity pattern of all the available drugs. And then it is coming up. And then artificial intelligence is being explored in reading chest X-ray and CT scan. Even collection of cough sounds are being explored on the basis of artificial intelligence to detect TB. So all these things are going on. A lot of work is going on as far as diagnostic front is concerned. Now, I'll just, before I go to the treatment, I'll just share you a case, which is very interesting. 22-year male, non-smoker, presented with cough, breathlessness, 7 years, recurrent hemoptysis, about 6 months. 4 बजे के बाद आओ. नहीं. Then he has symptom suggestive of TB. He say him TB and suggestive of breathlessness means asthma also, both. So somebody in this X-ray, maybe some higher prominence, somebody wrote him anti-TB drug, and when 6 months of drug was completed, after that, lesions have progressed. Now, anybody, if both the X-rays are shown to anybody, we can say that yes, if it was drug-sensitive TB, it must be a drug-resistant TB. So ultimately, what happens? He was suspected as MDR TB and was he came referred to me. What I did first, I did sputum smear, and I found sputum was negative. I said, if sputum is negative in such an extensive lesion, it can't be TB. It is something else. And ultimately, we have been able to diagnose with help of, eosinophil is very high. Skin tests to Aspergillus were positive. Total IG and IgG against Aspergillus fumigatus were highly elevated. So all the tests, which confirms allergic this is central bronchiectasis. They are all present in this case and was diagnosed as allergic bronchopulmonary aspergillosis. What 6 months of TB could not do it. No, about 6 weeks of steroids made all the difference. Because what I'm trying to say, you have to diagnose every case very effectively. Then you can treat. If the diagnosis is not good, there's no fun of treating those cases. Now, then I have come to how to treat tuberculosis, especially drug sensitive tuberculosis, because today my talk is not on drug register. You know, these are the common prescriptions. Even last two months before I got this prescription, a person he wrote the weight about 63 and writing rifampicin 450. Not a good dose. So this type of even 58 kg man, some orthopedic surgeon, TB spine wrote 4 COX-2 tablets. So I mean, these are not the good prescriptions because the dose is inadequate for such weight. So what I'm trying to say, when we treat with full heart. What is the aim of treatment? You should cure the patient if possible, prevent complication, avoid relapse, reduce transmission, limit emergence and the spread of drug. These are all aims of treatment drug sensitive. And we treat drug sensitive. Now, a lot of people, although the government is providing food, but what is the most important influencing the response to treatment is the adequate chemotherapy and regular intake. Even severity of disease, you have seen in the first case, very extensive disease. It is okay. And rest, accommodation, diet, nursing, climate, these were important. I don't say they are not important, but they are not as important as chemotherapy. If somebody is deficient in some of the diets, yes, you have to replenish it. So what I'm trying to say, treatment, chemotherapy is very, very important. As you know, basic principles always we adhere, no single drug, multiple drugs are used, and the drug mostly should be given in a single dose. If you cannot tolerate, you can divide it. And drugs, still we see prescription of pyrazinamides, 500, 750 milligram BD. Drugs effective dose, and if I have shown you 2 prescriptions, so drugs should be given for effective dose, and these are the basic principles, which ATT are available as a fixed dose combination, as a separate ATT. Choice is fixed dose combination today as per WHO suggestion. But separate drugs are kept reserved for those patients where there is a drug intolerance, where there is an adverse drug use. Fixed dose, there are many advantages of fixed dose combinations, but only disadvantage, major concern with fixed dose is that the substandard fixed dose combination. What WHO says, fixed dose combination, their bioavailability test must be done batches after batch. Although many of the companies are following it, but some are not following it. So when you write fixed dose combination, although in the government supply, fixed dose combination goes very bioavailability test, but in a private sector, wherever you go, patient purchases these medicine, then you have to be careful, write the quality medicine. And another standard of treating tuberculosis is any patient, any practitioner who is treating tuberculosis, he assumes an public health responsibility. That is very important. And to fulfill this responsibility, the practitioner not only prescribe the appropriate regimen, but also be capable of assessing the adherence of the patient. That is why, DOTS came, so many things are taken. But if you are treating a patient, it is your duty that your patient should complete the therapy. Then another public health responsibility today is a notification. So whenever you diagnose, whenever you treat, you should notify. Duration of treatment, since I'm talking of drug-sensitive tuberculosis, When you talk about the duration of treatment, what rule says that if you have used rifampicin and pyrazinamide in intensive phase and rifampicin and ethambutol and INH in a continuation phase, then this is the usually standard short course chemotherapy. Suppose in a continuation phase, you are not being able to use, although these regimens were previously there, but even today, sometimes you are not able to use rifampicin because of drug intolerance. Suppose in continuation phase, you are using INH and ethambutol, then regimen is not for 6 months. It is, although in the initial 2 months, you have used 4 drugs. If pyrazinamide is not used in intense anyway, suppose you are using rifampicin, INH, ethambutol, then total duration is not less than 9 months. And if rifampicin and pyrazinamide both cannot be used, today it should be used in every patient, but sometimes because of drug intolerance, it cannot be used. Then duration is not less than 1 year. So that is the basic rule, what is being followed to decide about the duration of treatment. Monitoring of these patients are done. Bacteriology is the most important. Molecular biology is not for monitoring. So bacteriology is most important. Radiology is the next important issue. Clinical assessment. ESR is very unsatisfactory. I haven't done ESR for my TB patients for the last 40 years. Treatment of drug-sensitive TB. When drug-sensitive TB, I'll go little back in the history. When you have started the drug-sensitive TB treatment, you have got 2 types of regimen. One was treatment of new cases, and another was treatment of previously treated. And in 2009 guideline, you have got like standard chemotherapy today is done, 4 drugs followed by 2 drugs. WHO also said in that guideline, if there is an INH resistance is high in countries where in a continuation phase, you can use 3 drugs. What government of India has adopted. So this was a 2009 guideline. So this was category 1 and this was category 2 where 5 drug regimen including streptomycin were used. Then even these regimens were then 2016 and 17. 16 ERS guideline came, 17 WHO guideline. And both the guideline has finally advised that category 2 treatment have been abolished. And now we have, this is the American ATS and ERS guideline. This was the WHO guideline. And what you see is in that guideline that you have got only 1 regimen. Category 2 was abolished. So in India also that adopted, and now we have got for drug-sensitive tuberculosis. Mind it, for drug-sensitive tuberculosis, if on day 1, if you have done gene expert, which is necessary today, then you know that whether it is a drug-sensitive tuberculosis or drug-resistant tuberculosis. And if it is a drug-sensitive tuberculosis, what you have to do is start with 4 drugs. That is, whether he is a new case, whether he is a previously treated case, all the patients, if there is no resistance to rifampicin, it means he is a sensitive TB, then you start with 4 drugs. Rifampicin, INH, ethambutol and pyrazinamide for first 2 months. And then in a continuation phase, as I said, India is a high INH resistance country. So in continuation phase, instead of 2 drugs, we use 3 drugs, that is INH, rifampicin and ethambutol. And total duration is, this is known as standard short course chemotherapy for drug sensitive, whether he's a new case, whether it's a previously treated case. So every case is covered under this. The continuation phase in certain conditions has to be prolonged for 3 to 6 months. And those conditions are CNS TB, skeletal TB, disseminated TB. So these are the situations where you have to prolong the continuous phase for 3 to 6 months period. So it becomes treatment for 9 months to 1 year. This is official guideline. Same is the ATS guidelines. In ATS, although I don't want to confuse, but Government of India has not adopted this. But in a private practice, sometime would do it that extension of DSTB apart from those conditions, neurological other, in certain situations can also be prolonged. This is advised by the ATS ERS guideline 2006 that cavitation or positive culture at 2 months, active smoker who is having diabetes also, underweight, HIV infection, extensive disease. In this scenario, we as a clinician sometimes prolong the treatment, especially the continuation phase, not the intensive phase. So this is advised by ATS and ERS guideline. Dose-wise, you have to be perfect. You have to take the weight if you are, whether you are using a separate drug or whether you are using a fixed dose combination. Here, now that it has been made very simple. 4-drug fixed dose combination followed by 3-drug 6 fixed drug combination, and this is divided into 5 weight bands, and you may as per weight band 2, 3, 4, 5, 6. You see, person who is more than 75 kg, here the rifampicin dose comes out to be 900, because in one tablet a fixed dose rifampicin has 150 milligram. So it means those formula of 450, 600, we used to tell, I have taught less than 50, 450 milligram, more than 50, 600, those formulas have come. So you have little higher dose of rifampicin and other drugs can be used. You have index guideline. If somebody is interested, someday we talk about the index, means treatment for extrapulmonary TB. And many people do ask, what is the role of corticosteroids in TB? Although there was little controversy, evidence-based, there are only 2 places where it is indicated, like tuberculosis pericardial effusion and TB. This is 2 places. But what we have observed, if I say that I have absolute indication, when severe TBM, cerebral edema, I have already told, miliary tuberculosis is associated with very toxic look. Yes, you may use it for some time. Severe drug hypersensitivity, you have to use steroid. Severe tuberculotoxemia due to this. And pre-terminal, I know that many patients, they come on a dying bed and you want to buy some time. So for some time, you may use the steroids. This is what we say, and the relative indications, usually you may use sometimes in pleural effusion, tubes, bronchi, intestine, fallopian tube, TB, but limitation you have to understand, wherever you are using steroids, there must be very effective coverage of anti-TB. That you have to be. In pregnancy also, most of the primary line drugs are safe. H are safe. If 3rd drug, you can add E. We have seen gynecologists treating tuberculosis. They stop the therapy. No, but this has been studied that at least primary line drugs have been safe. First 2 drugs are very safe. Ethambutol is safe even if you can use pyrazinamide. Diabetes, in diabetes, we always say diabetes has to be tackled properly. Unless diabetes is controlled, TB is not going to be controlled. So both the diseases must be treated. And in case of hepatotoxicity, you know that a lot of confusion do happen. But what rule says, suppose on ATT, somebody develops hepatotoxicity, then what happens? You usually inquire about the other medications as well as alcohol intake, investigate for other causes of hepatitis. So there you have to be careful. And then you do LFT. If LFT, SGOT and PT raised less than 5 times with normal bilirubin, with symptomatic, asymptomatic patients, what you have to do, suppose patient whose SGOT PT is less than 5 times, he is asymptomatic, bilirubin is normal, you can continue all the drugs, but monitor clinical symptoms. AST ALT means SGOT PT bilirubin level every 2 weeks till resolution, and you may continue the drug in this situation. Patient may tolerate. But suppose if the SGOT PT raised more than 5 times, bilirubin is raised, elevated, and patient is highly symptomatic, then what? You have to withdraw the drug and withhold at least INH, rifampicin, and pyrazinamide. And we may use initially, you may not use any drug if the patient is not very sick. If sick, you may have to use some drug which are hepatosafe like streptomycin, although it is rarely used today. Then ethambutol, these are the hepatosafe drug. Otherwise, when his LFT become normal, then you have to reintroduce the drug. And there are different ways of reintroducing the drug. What is American way, American Thoracic Society, they say introduce rifampicin first, then isoniazid, and then pyrazinamide. This is a sequence. But what European says that reintroduce BTS guideline, British guideline, they say you introduce first isoniazid, then rifampicin, then pyrazinamide. I personally like the British guideline, and what we do that if somebody's SGOT PT is raised, serum bilirubin is raised, and symptoms and then highly symptomatic, then this LFT, then we stop the drug except streptomycin, ethambutol, and levo, and then we reintroduce ATT like INH is introduced. To me, INH is very safe in India. Then rifampicin, and if we tolerate, even pyrazinamide can be reintroduced. But one thing you have to remember, what drug up to you have introduced, depending upon your duration will be there. If you have not used rifampicin, pyrazinamide, then 1 to 2 years. If you have used only rifampicin, duration is not less than 9 months. If I use pyrazinamide both, then of course duration becomes 6 months. So you have to be very careful while dealing. And in case of drug sensitive TB, renal impairment, in renal impairment, what happens that isoniazid no change, rifampicin no change. Change is required in pyrazinamide, ethambutol, and if we are using streptomycin. Mostly what we suggest, 3 times a week dose may be sufficient in this situation. Now, I have come to end of my presentation. I said I promise you that in the end, 3-4 minutes, I'll spend on what is the treatment of tuberculosis, especially the drug-sensitive tuberculosis in future. There are large number of new drugs are being tried. You should be happy if you're saying 2021. You might be remembering the REMARKS trial, where with the use of moxifloxacin, people tried to reduce this 6 months duration to 4 months. But previously, in 2014 and 15, we failed. So ultimately what happens, they say that treatment before this new guideline, I'll just share, 6 months duration remains the gold standard. This is still today. In India also it is true, 6 months, not less than 6 months duration. Good news I'm going to share with you. These studies are going on with last 2-3 years, and now it is published. Even WHO has published the new guideline for drug-sensitive tuberculosis. I'll just share with you. In this 3-arm study, in 1 arm, this is about 4.5 months of therapy, in which standard like you see 4 drugs followed by 2 drugs. Then rifampicin was replaced with rifapentin, high-dose rifapentin in one of the arm. And then another arm they weak, the rifapentin high-zode, INH, pyrazinamide, and ethambutol they have replaced with moxi. So this is regimen again for 4.5, means 4 months plus 1 week. So what they did, what they in the study, they found that this regimen having about 4 months of treatment, what we call is a rifapentin mox study. And there, no significant difference in unfavorable outcome. Rifapentin and mox regimen was non-inferior and was just effective as the standard 6 months regimen. So what I'm trying to say, this study was published in New England Journal of Medicine last year, and good news is 2020 WHO guideline of drug-sensitive TB has just been released, in which what they have advised, the two things they have advised in this new guideline. It is still not being adopted by Government of India, but Government of India will take call on it and decide. But what is good news is what we were thinking in Remox trial, we failed. But now with this trial, people aged 12 years or older with drug-sensitive pulmonary TB may receive a 4 months of isoniazid rifapentin. This is not rifampicin. And the moxifloxacin and pyrazinamide. New recommendation. This is already WHO has cleared. This is WHO guideline which has just come. And even in, they say this guideline also say one more thing. For children, in children, adolescents between 3 months to 16 years of age, with drug-sensitive tuberculosis, 4-month treatment regimen, same standard regimen should be used. A new recommendation. This is so for adults more than 12. This is a new regimen for 4 months, and same what 6 months in children in a different situation. But rider is that still Government of India has to take call on this WHO guideline and has decide for the country. And so you'll be going to see what is dream. With this dream, we have been there for last so many years. Can we have less duration treatment? Yes, today to me, it appears dream has come true, and very soon 4 months therapy will be introduced for drug-sensitive tuberculosis. With these all studies, I wrote an editorial in Indian Journal of Chest Disease 2020. Are we moving towards universal development of universal drug regimen? Yes, we are moving towards that direction. Probably all drug-sensitive and even drug-resistant TB will be treated with one regimen, maybe 3 months for sensitive, maybe 6 months for drug resistant. So what I am come to end of my presentation, I said two take-home, very important take-home messages. What with this bar diagram, you try to understand, this is what was the natural trend of TB. When TB treatment was not available before 50s, this study was done in NTI Bangalore in 60s. If you don't treat, what happened? Half of them will die. 33% will become sputum negative under their innate resistance. 18% will excrete tuberculosis-like. If you give good treatment, death rate will be drastically reduced. Most of them will become negative and sputum positive will be reduced. But if you give a bad treatment you have seen in inadequate, do so many things, then although you will be able to reduce death rate, you will be able to increase the sputum negativity, but sputum positivity remain the same. This is not statistically different. But what is the difference? This negative, when there was no treatment, was without drug exposure. So there was no drug resistance. But this bad treatment will be with the drug exposure, so there will be a lot of drug resistance. So with this bar diagram, what I say, it is better not to treat than to mild treat. Please remember this step. If you want to treat tuberculosis, I said in the beginning, use your full might to treat drug-sensitive tuberculosis. And your diagnosis, another thoughts I give, your diagnosis must be correct. Suppose your diagnosis is not correct, you are likely to fail. Drug susceptible TB, we have already said, this is a standard regimen. This can be extended for 3 to 6 months. Compliance is very important. Notification is very important. And empirical treatment is also in some cases you have to take. And last line, which I'll add, which is not added, probably 4-month treatment, which has already been advised by WHO, will be possible in times to come. With these few words, what I'm trying to say, my lectures are available on. I have many more YouTube lectures like how to take history, and then how to do physical examination, how to do auscultation, how to read chest X-ray. All sorts of YouTube lectures of mine are there. If some of you are interested, some of you might be seeing it, interested may go on my YouTube and see. And we have got many books in tuberculosis, which I've tried to shorten it within 45 minutes of time. So with these thank you very much for very patient listening. Now, now next 5-10 minutes, we'll be here. We have enough, we have time. So if you have got any question, I'd love to answer those questions. Thank you very much.
Thank you so much, sir, for a wonderful and insightful presentation from your side. So, sir, there are several questions from the audience side.
Yeah.
So first question is, you mentioned in your presentation, there are several factors which increase the patient's susceptibility to the treatment. So what is your view on that?
You are not audible. Please speak again. There's some interruption in your voice.
Yes, just a minute. I will stop my video. Maybe because of some. Just a minute. Right now, is it okay?
Yes, okay.
Yeah.
Go ahead.
So there are several factors you mentioned in your presentation. There are several factors which increases the patient susceptibility to contracting to tuberculosis. So what is your view on that?
Several factors. Patient, it means, immunity must be good. That is one very important factor. Somebody gets HIV. Why he gets tuberculosis? Because his immunity goes down. Somebody gets diabetes and it is not effectively controlled. He gets we see day and day out cases like this. So suppose somebody is malnourished, BMI is very poor, is likely. Somebody is using alcohol, is likely to get tuberculosis. So these are the factors which are causing the tuberculosis. Although we Indians, majority of us are infected, but we are not getting disease. But the day our immunity goes down, that infection, which is sitting idle, will convert into a disease and it will get the tuberculosis. That is very simple.
Thank you so much, sir. Second question is, what is causing the TB to become a serious public health issue?
You have seen the science. I always say the science has advanced. Today, I'm not talking drug. Someday I'll talk about drug-resistant tuberculosis. Science has advanced. Science has advanced to this level that even 4 months treatment has been just recently advised. So, but problem is its implementation. I know that I said in my first slide, if I prescribe the treatment in correct way, and if I made my patient compliant, this is my duty. If I'm treating, because I have assumed the public health responsibility apart from being a clinician. So if I complete, whatever way you take, you give education, you counsel your patient, you send to the government for DOTS program, so whatever, but you see that patients complete the therapy. Then these are, so between the real thing which should happen is not happening. You have seen in time I spoke to you, more than 30 people must have died with tuberculosis because of the poor implementation. Science has progressed to extent, when I was lecturer way back in 80s, we used to wait for diagnosis of tuberculosis, drug-resistant tuberculosis for a long. Now we have got very quick diagnostic method. We have new drugs to treat. So everything has happened, but only thing we have to be ourselves has to be very careful, treat every patient effectively, make your patient compliance. This I'm sure I can give you guarantee, because I myself have treated, that your outcome would be much high than what you used to get.
Thank you so much, sir. Another question, sir. What is the difference between the rifampicin and the rifampicin?
Rifampicin is actually the derivative of rifampicin. You know, rifampicin is having a long half-life. Otherwise, it is like a rifampicin. Rifampicin is not a new drug. When I was doing PG, once you have a bi-weekly treatment at that time, and we were also there has been studies which are saying that rifampicin can be given once a week even. And you know, in our preventive therapy, rifampicin is going to be used once a week along with INH. So it's a duration of action is very high. So it can be used as intermittent therapy also. But here, the regimen, what I have shown here, the rifampicin high doses will be. Otherwise, most of the side effects, most of things are like rifampicin, like rifampicin, because it is a derivative of rifampicin.
Thank you so much, sir. Sir, maybe this is the last question. So you mentioned in your presentation about the Remoxtile data, there is a non-inferior data with the rifampicin versus the standard of therapy. So what is your view on this? Because the WHO already mentioned the recommendation for this 4-month treatment.
I think to me also, as they have carrying out this study. I'm following this study for last two years, and now they have published in New Journal of Medicine, and now taking all these things for publication. Even WHO has recommended this. They have advised for whole world that you should go for these regimens. So I am very hopeful. Government of India will take call, and will sooner it is going to come in India also.
Okay. So sir, right now there are no more questions from the audience side. So can we close or wait for some time?
Yes. So my final take-home message, what I was, some of you must be remembering that slide. Please don't treat tuberculosis half-heartedly. Please treat with full heart, full might, and educate your patient to this extent that he completes the therapy. I'm pretty sure that you will be able to treat most of the drug-sensitive tuberculosis very effectively. You will be helping the society, and that will also reduce the development of drug-resistant tuberculosis. So these are the advantages treating a drug-sensitive tuberculosis. With these words, I must thank the Lupin, who has organized this ECME. This is not the first time I am delivering for ECME, but this such type of endeavors must be taken, so that because we know, my feeling is education in tuberculosis has gone down. Most of the companies has withdrawn from education in TB. And you know, anything cannot done only by the government. Private sector has to come forward, because countries are very huge. I can't understand why people are not writing the correct doses. Why people? It is not their fault. It is the poor education, I always say. So we have to increase education, and I must thank Lupin Pharma for taking this initiative and educating our doctors. So thank you, Lupin, once again, and thank you all the participants once again for listening carefully. Thank you very much.
Yeah. Thank you so much, sir. Sir, we have received one more question from the audience side. So can we?
Yes.
Yeah.
Yes.
So should we start the ATT CAT1 after we get positive report from the AFB, or should we wait for the report of the CBNAT, LPA, or culture?
No, one thing one has to be understood. These molecular tests, they are not for follow-up. They are for the diagnosis for the first time. That should be very clear. Follow-up is for the smear or culture. Yes, you said somebody is sputum positive. And in sputum positive, you can do at that time also gene expert. If it says rifampicin resistance, probably you have to change the treatment to drug resistance. So that is what effective steps you have to take.
Okay, thank you so much, sir. So, sir, can we close the session?
Yes, yes. Thank you very much.
Yeah. So thank you so much, sir, for a wonderful and insightful presentation from your side. And also, I would also like to thank the audience for their time and patient listening. Thank you so much.
Thank you. Thank you very much.
Ravinder ji?
Yeah.
Yeah.
Thank you, sir.
Thank you, Ravinder. Thank you.
Thank you.
भाई इसकी